Hi, I'm Lisa Nainggolan of the Heart.org, and I'm here today with Dr Bryan Williams of the University of Leicester, UK, to discuss the new hypertension guidelines in Britain, which were issued by NICE last week. Hello, Dr Williams.
Hi.
Perhaps you'd like to outline with me what are the main new features of these guidelines.
Okay, so NICE has issued new guidance, and it's primarily about the treatment of hypertension and the detection of hypertension in patients with routine hypertension, if you like. So the primary features of this guideline which have changed are the diagnosis. We've made a recommendation that patients should undergo ambulatory blood pressure monitoring to diagnose high blood pressure or confirm the diagnosis. So that's quite an important change.
And that means 24-hour blood pressure monitoring.
24-hour blood pressure monitoring, preferably. We've also made some changes to our treatment algorithm, specifically in relation to the hierarchy of prescribing of calcium channel blockers and diuretics. So I think there are important changes. The ABPM change, the ambulatory monitoring change, is a completely new development, and the changes to the drug treatment really represent evolution of the processes that we've been evolving over the past few years.
I understand the recommendations for ambulatory blood pressure monitoring are the first in the world to recommend this as the best way of diagnosing blood pressure. What impact do you feel this guidance might have in other countries?
I think it's really important. I mean, in fact, one of the questions that we set ourselves when we reviewed the guideline this time was, what is the best way of diagnosing high blood pressure? Pretty fundamental question.
Sure.
And if you look at the way things are, they haven't changed for more than 100 years. Going to the doctor, getting your blood pressure checked. We never based treatment on a single reading. We've always needed multiple readings. So we looked to see whether multiple readings taken over the whole day with an ambulatory monitor would be more sensitive and more specific at diagnosing blood pressure in a patient who hadn't yet been treated or diagnosed. And what we found is that it is clearly the most effective way of confirming the presence of high blood pressure, even more effective actually than a series of home blood pressure monitors, but that's sat somewhere in between what we do now and the preferred method of ambulatory monitoring.
Do you feel that patients would find ambulatory monitoring easier than home blood pressure monitoring because they just have to wear something rather than actually
for diagnosis, what we're now saying to the doctors is that if the patient you think the patient might be hypertensive, offer them ambulatory monitoring. I think most patients would be very happy to know that they could wear a monitor for 24 hours. You can wear them pretty unobtrusively, and monitors are now being developed that are much smaller, some of them even worn around the wrist. So I think the whole technology is evolving. They can be worn in such a way that it's not particularly obtrusive. It's only a day's monitoring. And at the end of that day, we'll have enough information to say whether or not the patient is hypertensive. And I think that's a very important advance. I mean, rather than somebody having to come back repeatedly. When we looked at the data, we found that maybe 5%, at the most 10% of people are unable to tolerate blood pressure monitoring this way. There is one other group where it can't be done, and that is in patients who have a highly irregular pulse, such as atrial fibrillation. Clearly, under those circumstances, any form of electronic automated monitoring is unreliable, and so we still have to resort to listening over the brachial artery, and etc. But I think, as a recommendation, it's bold, but I do think it's the right one, and I think it will be replicated around the world.
You also found, perhaps to your surprise, that it was actually cost effective. Would you like to talk us through that a little bit?
Yeah, I mean, one of the interesting things is when we had the panel discussion and I was chairing the panel, we said, okay, we've looked at the data. It looks like this is the best way of making the diagnosis. But the big question we all had in our minds is how much is this going to cost? And is the health service going to be able to bear this? So we did a formal cost effectiveness analysis. And in that, we looked at the cost of buying the monitors, servicing the monitors, replacing the cuffs, even replacing the batteries, training the staff. And we offset that cost against earlier diagnosis, less doctor visits, and potentially up to 25% of people who would otherwise be diagnosed with the standard diagnostic procedure in the clinic not being diagnosed by this procedure, because undoubtedly there is a high percentage of patients who are normotensive when you measure their blood pressure away from the doctor's office. So once you figure all that into a cost-effectiveness analysis, we found that at the end of a year, then it is an excess cost because you've had to buy the equipment. But by the time you get to 2 years, it's cost neutral for an average practice. And by the time you're getting to 3 years, in the NHS and the National Health Service of England, we modeled this to suggest it would actually be cost saving, millions of pounds cost saving. That's pretty extraordinary.
Yeah.
There aren't many interventions in healthcare that within 3 years that actually cost money up front lead to a cost saving for the healthcare. And that's why I think it will be very interesting to other countries, because I know there's been a resistance to payers or reimbursement for ambulatory monitoring. Why would you not reimburse a procedure that's actually going to save you money? I mean, it's extraordinary.
And how do you see this rolling out in the UK amongst general practitioners, family practitioners?
Well, I think there'll be some early adopters, the people who generally be progressive and probably already have the equipment. There's going to be some challenges in different parts of the country where the provision of ambulatory monitoring is restricted to secondary care, or it's not widely available at all. We have in our country and in many other countries now commissioning groups, and they're going to have to get together and come up with innovative ways of making sure that this technology as a diagnostic procedure is easily accessible, and that might be hubs or of provision where people can go along and say, I've been asked by my doctor to get this done, get it done. 24 hours later the report goes to the GP, and the GP can then make a decision. So I don't see the challenge as insurmountable, but we recognize there is an implementation challenge. But I think once you realize it's going to save the service money in the long run, then we should be doing it.
Great. Perhaps you could now talk us through a little bit the changes you made in treatment recommendations as well.
Yeah, I mean, when you look at guidelines, people are always interested in what we say about drugs. And just to perhaps recap, what we said in 2006 was that for younger people under the age of 55, we would start with an ACE inhibitor or an ARB if you were ACE intolerant.
Yeah.
Because at that time, we didn't know whether an ARB was as equivalent as an ACE.
Sure.
We've now concluded that the data suggests that they are equivalent in terms of protection, so it's gone to ACE or ARB for the under 55. So that's straightforward.
And there is an ARB available generically in the UK now?
Yes, and in fact, NICE in the UK would argue that it should be a low-cost ARB.
Yeah.
If you go to the over 55s, and also people of Black, African or Caribbean origin of any age, we recommended last time a CCB or a thiazide diuretic. What we've said this time is if you look at our cost-effectiveness analysis, a CCB seems to have the edge over almost all other drugs, actually, in terms of preventing stroke and heart disease. So we've said for the majority of patients, first-line treatment for that group over the age of 55 would be a CCB, giving a very strong steer.
Yeah.
Now, some people have interpreted this as a relegation of diuretics. It is to some extent. We're now saying diuretics are used later. But we make the important caveat that if you get edema on a CCB, or if you already have edema, or if you're at risk of heart failure, then we would still recommend a diuretic as first line. At step 2, we recommend combining either an ACE or an ARB with a CCB as the preferred treatment now.
And that would be in the people younger than 55?
Well, that's anybody. Because, of course, if you're younger than 55, you'll be on an A and you'll combine with a C. And if you started with a C, you'll combine with an A. It's very simple now. It's A or C, and then A plus C at step 2. And then at step 3, that's when the diuretics come back in, and we have A plus C plus D. So it's ACE or ARB plus calcium channel blocker plus a diuretic. Now, we've also changed our recommendation on diuretics. There's been a lot of controversy about whether bendrofluozide, which is used almost exclusively in the UK as a thiazide, or hydrochlorothiazide used in the rest of the world, whether they have as much evidence as the alternative thiazide-like diuretics, which also act like thiazides but have additional actions on the tubule, such as indapamide and chlortalidone. We looked at the data. To be honest, the data is very thin, and some people have made claims that the data strongly suggests that we should be doing this or that. It doesn't strongly suggest that at all. It's actually quite weak, the data, in comparative terms. But what we decided was that we didn't have any data for low-dose bendrofluozide, which is widely used in the UK. So we said, well, we need to change that. And based on what we did review, it looked like the data with the lower doses of chlortalidone, 12.5 or 25 milligrams a day, or indapamide, 1.5 milligrams slow release, or 2.5 milligrams a day, there's more data with those drugs on outcomes than any other diuretic at the moment. So we've recommended that if our doctors are contemplating giving a thiazide-like diuretic, then they should use either the indapamide or the chlorthalidone. But they don't need to change the diuretic that patients are already on if blood pressure is well controlled.
If they're happy.
Absolutely.
Okay. And beta blockers stay fourth line?
Yeah, I mean, and you know, when I go around the world, people often say, "Oh yeah, you're the guys who got rid of beta blockers for hypertension." That's a little bit unfair. I mean, the evidence got rid of beta blockers for hypertension. We were bold enough in 2006 to say beta blockers work. They reduce heart disease and stroke, but they don't do it as well as the other drugs we have. So we decided to retain that recommendation. Beta blockers can still be used later on in the treatment cycle, but we think we've got better drugs now. So we've moved in maybe 5 years from a beta blocker diuretic being almost the standard treatment for high blood pressure to now using an ACE or an ARB with a calcium channel blocker as the preferred treatment and bringing back the diuretic in the more resistant cases.
And other countries have followed that guidance on beta blockers and downgraded it. Is that correct?
I mean, other countries have now begun to reevaluate the role of beta blockers in the treatment of hypertension. Some of them have actually amended their guidelines. It'd be interesting to see what the Americans decide to do with the Joint National Committee. I heard only today at the ESC that even in patients post-MI who don't have heart failure, they're thinking about downgrading the recommendation on beta blockers. So I think the whole mood about beta blockers is changing, and I certainly think we've got better drugs for people with hypertension, unless they've got angina or heart failure, in which case they're still very useful. But the thing I like most about what we've managed to do with the NICE guidance is make the whole process incredibly simple. You know, you think somebody's got hypertension, do an ambulatory monitor. If it confirms hypertension, treat them. Lifestyle, drugs. If it doesn't confirm hypertension, then you can put back into a review cycle. If they don't tolerate ambulatory monitoring, you can go to home monitoring. And we give recommendations about how to standardize that. Once you start treatment, young, A, old, C, combination A plus C, and then A plus C plus D. I mean, I'm of the view that when you're making guidelines for common conditions, we should be able to get the information on a single page.
Simplicity is key.
Absolutely, because this is not about trying to show how clever you are by writing hundreds of pages. It's about implementation. It's about saying, how can we make this evidence-based and also implementable? If you argue that you can give anybody anything, then nobody's going to give anybody anything. And that's the problem. And so I think our guidelines, if they're followed, will lead to better blood pressure control and more appropriate treatment of the right people. And that's really important. And all of it's cost effective. I should finish by saying that the treatment of high blood pressure itself, we looked at the cost effectiveness of that. And we found that, again, remarkably, treating high blood pressure, even taking account of doctor's visits and the drug costs, treating high blood pressure is more cost effective than doing nothing at all. That's amazing. You know, so people think it's expensive, but it's actually cheaper in the long run to do it because the cost of people having strokes and heart disease, the cost of lost work and capacity is disastrous. So this is a really important guideline because it affects so many people. And I think the recommendations, if they're implemented, are going to improve care, and they will influence the rest of the world.
Thank you for taking the time to tell us in more detail about those guidelines. This is Lisa Nainggolan from the ESC. I've been chatting with Dr. Williams about the new UK NICE hypertension guidelines. Thank you.